you speak to your Minister of Finance, please don't say, I need X million dollars because I'm doing God's work and I'm working on health. You might say, we need X million dollars because we're going to avert this many maternal deaths and this many child deaths, and we estimate that this is going to be the contribution to economic growth. And so on and so forth in terms of the tools that are available there and the methods that we use, such as conditional cash transfers to reach poor households. Right. Now, let's go for some numbers here. This is a rather busy slide, but we decided to keep it because it actually shows us some of the gains that can be had. So when you make some specific changes in the cold chain and transport system for vaccines, I know that only people who are under the age of 10 can read anything this much from afar. So you're going to have to trust me on this one. What it's saying, for example, is if we implement a strategy that makes it possible for vaccines to last longer under moderately high temperatures, you actually get a 50% reduction in the cost of the cold chain and the logistics system. That is up there. And there are all sorts of other changes here, and you can see the percentage gain there. So these are innovations taking place on the continent. They don't necessarily have to be imported from outside the continent. However, pilots are not enough. They are necessary, they are not sufficient. We have to work at scale, and we have to sustain them. Some years ago, about 10 years ago, we were in Mozambique. And we were in a round table, and it turned into one of those discussions that you remember. Because there was quite a bit of, shall we say, angst about whether a program that was going to be done was going to be sustainable. And I would like to take us out of here into some of those villages. Because what our colleague from Mozambique said on that day stayed with me. So I'm going to quote. Said, look, we're trying to do something with the intention of making it work. We know it won't be easy, and we know it will be a challenge. But we are not afraid of the need to sustain success. We think what we should avoid is to sustain failure, which has been the case for years. And this needs to stay with us. The power of success, which this framework can help to intensify, lies in the communities on the continent themselves. It lies with the parents, it lies with the community health workers, it lies with the local governments themselves, it lies with better governance. And what we do at the community level really, really resonates. So if you just indulge me for a moment, I just want to recognize the presence here of the one and only Professor Miriam Were, who was my boss some 20-something years ago, for all she drilled into me about the importance of work at the community level. Let's give her a hand. Another thing is to be very bold in seizing the successes and capitalizing on them from the countries. Some years ago, we were at the Holiday Inn in Nairobi, planning the pre-launch of what we call the Affordable Medicines Facility for Malaria, which was an innovation to take subsidized medicines through African supply chains and African private sector outlets. And a colleague stood up and said, this is never going to work. Whoever tries this in Kenya should be shot. And he was saying it in the most positive sense possible. Well, according to the independent evaluation, it worked. And in Kenya, the availability of affordable medicines in Kenyan private sector outlets increased from 20% to 60% over a period of less than 18 months. So what we learned from this in Kenya is African private sector supply chains, African outlets can actually get these products from point A to point B. So this is telling us of the power of local innovation and the partnership between the public sector and the private sector to get things done. It also challenges the way we practice development assistance for health. Let us do those things in ways that are supportive of country systems rather than substituting for them. So, what are the 5 areas on which we should really pay attention? Please, if we remember nothing else from this session, let us try and remember the following 5. The first one, is financing. There is a need to make better use of the money already available. This is the value for money proposition. Get more health from the money that's already available. There's also a need, unquestionably, for more money. And the first shilling, or the first dollar, if you like, should come from the countries themselves. And this is where domestic resource mobilization comes in. Allocation from existing budgets and better tax collection systems within the countries themselves. And also the fairness, just the fairness of the financing mechanism. This is where, in many countries, government budgets do come in. Because in many countries, informality is still the norm. And when you have informality, it is really not feasible to have the classic social health insurance as we know it. Therefore, in order to avoid a situation where people fall between the cracks or they are left behind, this is where government needs to step in. So, more value for money, more money for health, just as we're getting more health for the money. And in that context, development assistance then becomes useful because it is in addition to, not a substitute for, the country's own expenditure. What we have seen over the last 2 decades, for example, is that in many cases, development assistance ends up displacing, i.e. substituting for country expenditures. And this is not the way it is supposed to be. Next slide, please. Services. It starts with the people, recognizing that at the end of all the systems we set up, that woman in Kisumu and that child in Kaduna and the cab driver in Dakar who need health services. So what is it going to take to ensure that we focus on the baseline health situation in the communities, that the facilities work, that they are properly managed, that supply chains work, and yes, that they work properly, that money does not leak. So we put in place effective public financial management systems to ensure that money gets where it is supposed to go, that we put in place public expenditure tracking service so it doesn't leak. I think this is really, really important. It's not only because it is the right thing to do, it's because it is the fair thing to do, and it is the honorable thing to do. It's no use expecting the taxpayer in London or the taxpayer in Kentucky to keep contributing money to development assistance for health if they feel that, well, at the end of the day, somebody is going to pocket that money rather than spend it properly. Next slide, please. And while we're on services, the multi-sectoral action is crucial. We have heard about water and sanitation. Really cannot overemphasize that. As we speak here, all over the continent, there are people with typhoid infections. Some of them have intestinal perforations, and so you treat them, but then you send them right back into the same communities. And it's just a waste of time because you keep going round and round and round. So ensuring that investment in potable water, investment in sanitation, that they come through and they are available at community level, these are very wise investments. Same thing with girls' education. Now, on equity. Now, treating people equally does not mean you are treating them fairly. You take somebody who is 7 feet tall, if you give him and me shirts of the same size, you have treated us equally, but you have not treated us fairly. So we need to really pay attention to the underserved, and we need to be sure that we avoid elite capture at the country level. Now, this is easier said than done, I know. But in too many of the countries, there's elite capture. A disproportionate fraction of government health expenditure goes towards tertiary hospitals that deliver services that only benefit or mostly benefit only the elite in the society. Now, this is where country leadership again comes in. The accountability dimension comes in, having data in the public domain that shows the level of coverage across the board, but more importantly, the distribution of those expenditures and the distribution of service access and coverage across groups in the country. Leave no one behind. Slide. Then preparedness. Somebody somewhere said Noah built the ark before the rain started. And I think that is what I would like to say here. Noah did not build for the rain to start. He didn't wait for the rain to start before he built the ark. But if you look at what happened during the Ebola epidemic, that is exactly what we did. And this covers multiple dimensions. It is building the institutions, ensuring the functions for routine public health functions of prevention, detection, and early response. It is surveillance systems, it is the integrity of the data systems, it is the credibility of the system at the interface with the community level. It is working at the country level to be sure that subnational entities share data and subnational entities are supported by and responsive to the national entity. It is working across boundaries and working across borders, such as envisaged in the African Centers for Disease Control, for example. And if we do this, or let me put it differently, when we do this, it means that countries will have fulfilled their own responsibilities under the international health regulations. Because let's face it, right now, most African countries have not. And this is very sobering. Most African countries have not fulfilled their responsibilities under the international health regulations. It is not appropriate to not do this, wait until epidemics come, and then call on outsiders, come and save us. Permission to speak candidly. If countries really put in the effort, it also means that should a potentially devastating epidemic start to grow, potentially becoming a pandemic, it means that money available from a facility like the Pandemic Emergency Fund will then be usefully deployed. Last slide. And on governance, this is the bottom line. The probity of government, the transparency of institutions, the accountability of different parts of the institutions, the social dialogue at the country level, all of this come together, grounded in policies, facilitated by public financial management to make sure that resources are well used. Finally, so this is the final slide. The time is now. We've already lost 1 year in the march towards the target for universal health coverage. We don't have many more years to lose. I'm not going to read out all of this in detail. There's variations across the continent, not one size fits all, but a few principles are applicable and adaptable to all, and let's venture forth in that spirit. So the call is for intensification of country leadership. The call is for a demonstration of leadership and country seriousness by deploying country resources in this. The call is to build institutions that work. And then the call, of course, is on international development agencies, including mine, to step up our efforts, to continue our partnerships, and to put ourselves at the service of the countries. Asante sana.
Thank you very much, Dr. Adey. Can I ask the panelists for the next session to please start coming up and take your seats? We're running very short of time, as you all may have noticed, so I will ask each of the panelists to be as succinct as possible, as direct, as brief, as to the point. As they come up, just to reiterate some of the things Dr. Adey has told us, particularly impressed by the paying for results approach, very innovative. He says we need to avoid the sustenance of failure. I told you I love African proverbs, so I'm giving you this one. No matter how many times you milk a cow, ladies and gentlemen, it will never produce butter. No matter how many times you milk a cow, it will never produce butter. Can we do the right things? Access and quality of care, water and sanitation, skilled health workers, capacity to manage public facilities, government funding is critical. We cannot continue, as we are told by Daktari, to depend on the kindness of strangers. The framework for action has been shared, and so allow me, ladies and gentlemen, now to hand over to the Regional Director of WHO, Dr. Moeti, who will take over the roundtable session. Let's give him a round of applause, please. It's Ms., excuse me. Let's give her a round of applause. Thank you so much.
Thank you. Thank you very much. I'm promoted to a male. You should clap. Okay. Excellencies, honorable ministers, partners, colleagues, and friends. I have the great honor of having been asked to moderate this panel. I also face the great challenge of helping our panelists do their work in a very restricted timeline. We're told to be succinct. So I will be succinct, but I'd like to start off by picking up where we left off in the first session of our leadership, that we showed in Africa that we can do it. And I had the great honor and huge challenge of being the program manager for HIV/AIDS in Africa in WHO when this 3x5 initiative was launched here in Nairobi. And we had to overcome all sorts of barriers, including a lack of belief in our continent's ability to deliver. And we are here today celebrating. So I'm very confident that if the Kenyan government and leadership is kind enough to invite us back, in a few years' time, we'll be back here celebrating progress and success towards UHC. We have a very eminent group of panelists, and I'm asking for their forgiveness in advance because I will not be able to introduce them individually. But I'd like to say we have Dr. Nicholas Muraguri, who's a permanent secretary in the Ministry of Health in Kenya. We have His Excellency Dr. Alexander Segbefia, Minister of Health of Ghana. His Excellency Dr. Tedros Adhanom Ghebreyesus, Minister of Foreign Affairs in Ethiopia, who's already spoken to us today. Her Excellency Dr. Raymond Goudou Kofi, the Minister of Health of Cote d'Ivoire, and Dr. Kithinji Gitahi, who is the Chief Executive Officer of AMREF Health Africa. Among these distinguished public health experts, we have a geneticist, an economist, a medical doctor, a public health expert, people who have worked in both the public and the private sectors. And what they share in common is leadership, vision, energy, and on-the-ground, hands-on experience in improving health in Africa. So please, I'd like to welcome our panel before I introduce our first speaker. Let's give them a hand. We've had very in-depth introductions from both the Honorable Minister of Health of Japan and our friend Soji Adei, who totally abused the time given to him. But this has given us really in-depth understanding both of the experience and of the principles and recommendations for universal health coverage. We are now going to hear, as I said, from experts who have held leadership positions, have developed strategies, and have had the experience to learn from what they've done, and are now going to also share with us their thoughts on what was suggested in the introductory presentations. So without much ado, I'll call on Dr. Muraguri from Kenya, whom we'd like to address a couple of questions related to financing. So Nicholas, if you could share with us, how could we or you increase government spending on health and mobilize private resources without discriminating against marginalized and vulnerable populations? So addressing equity. And also, how could we improve efficiency of development assistance for health and make donors aligned with national health policies and strategies? We've already had introductions of some ideas on this. Nicholas.
Okay.
Dr. Nicholas Muraguri, you have the floor.
Yeah, thank you so much. I want to be short and precise. In response to that issue, I first want to appreciate that in Kenya, 30% of total health expenditure is from out of pocket. And that exposes a lot of people, particularly very poor and vulnerable, to poverty. And in Kenya, we have been advocating for health, and for a long time, we have been trying to position health as a prerequisite for any social transformation that we are having. So health, not necessarily an expenditure, but health expenditure, health investment in health is a prerequisite for our social transformation. And of course, it has direct impact on economic growth. We have also been advocating that even when you don't have enough money in the health sector, we can prioritize on diseases that affect the most vulnerable and marginalized population. And that is why we have removed financial barriers to access to programs for HIV, tuberculosis, and malaria. We also realize that 25 to 30% of our deaths are associated, are related to maternal health issues. That is why we have introduced free maternity. We have removed the financial barriers so women are able to deliver for free in our health systems. We also appreciate the need to promote preventive programs. That is why we're investing a little money in programs, vaccine programs that ensure that people remain healthy, therefore reduce demand for curative services. Having said that, we are now moving towards universal health coverage and finding a system of efficiency. We are aware that that certain population, although we expand in insurance in total, we know certain population cannot be able to access insurance, and we categorize them into two. There are those very poor cannot be able to pay for themselves, and the government is mobilizing internal resources and also external resources to pay insurance for that kind of category. But we also know with our economic growth, we have a growing population of Kenyans who may not be able to pay $60, for example, per year per family for insurance, but they can pay $10, $20. So we're introducing insurance subsidy for that kind of category of people. Collectively, know if we're able to introduce risk pooling, for promoting for those who are able to pay, they pay, make it easy for them to pay. And I'll give an example. Before, for you to get insured, you had to go get you ask for several things. You must have a photocopy of an ID. You need to have you must have a passport photo and so on. But using technology, you have made it easier for a farmer in rural homes to be able to register for insurance using the mobile phone. So that way we're able to remove the barriers, technology barriers that many people, even those who are willing to pay the little money, $60 per year, to access. Collectively, we strongly believe that programs that are aimed at protecting the poor people are possible. We need to increase more money to the health sector because we keep arguing. Africa is rising, we have a lot of transformation infrastructure, we are building new schools, building roads, harbors, and so on, new industries. Sick people cannot take up the economic opportunities that are coming up, like jobs. Sick people cannot go to school. Sick people cannot work, and therefore the interlink between health as an important asset for social transformation is always emphasized. And coming over to the second part of the question, which is basically how to improve efficiency development assistance in health and making the donor aligned with national health policies and strategies. We strongly believe certain things. We must be sure, both political leadership and administrative leadership in our ministries, must be sure of what they want and where they want to take the health sector. Because you shape where you want to take your partners. So strong administrative, technical leadership, political leadership is important. With that, we're able to define policies, we're able to define strategies that addresses our health priorities. And then naturally, then partners, we're able to align themselves to those policies and strategies. For Kenya, we've been pushing for partners to come as one, harmonize themselves as a group. So basically, delivering as one, as partners, and because all of them are aligned to our strategies, then our framework for results is one. So we demand certain results, we all share with a shared responsibility. We have also been insisting that we need a robust, resilient health system. And when you look at our health system pillars, we have identified areas that need investment in, from human resource development all the way to supply chain. That is why for this country, for example, we have invested collectively with our partners in strengthening our supply chain system. It had many channels of input. We have now harmonized that into one supply chain system in the public system. That way, all of us are able to have efficiencies of scale. So all ourselves, the government, money, global fund, our partners, then are able to use our robust public health system procurement agency. So I just want to give those examples as one way of ensuring efficiency, harmonization. Bottom line, African leaders, both technical and political leaders, must know where they want to take the country. Very clear. Define your priorities, then everybody else will align to that. And then, of course, all demand for accountability and results. Thank you so much.
Thank you very much, Dr. Muraguri, for having shared Kenya's experience. I have to congratulate you on harmonizing the supply chain management. I'm sure you've seen the slide about Kenya's supply management system, maybe 10 years ago, that was doing all the global conferences. So really, congratulations for that achievement, and for sharing with us what you've done in Kenya in terms of insurance, pooling of resources, dealing with the issue of those who are most vulnerable, and also using technology. Kenya is the leader in this in general, and congratulations for using that as well in health insurance. I'm sure we could hear much more about how you got, or how you proposed to get the partners to align, because having a national policy is one step, but getting alignment around it by the partners is another. But we'll hear more about this from the other panelists. It's my great pleasure now to introduce the Honorable Minister of Health, Dr. Alexander Segbefia, who is going to tell us about Ghana's experience. We know that Ghana has been one of the leading countries as far as working towards universal health coverage is concerned, and have established a health insurance scheme that has been in operation for a number of years. So, Your Excellency, could you briefly describe your experience with the National Health Insurance and CHIPS in Ghana? How do you evaluate their progress to reduce financial risk of households due to out-of-pocket health expenditures, about which we heard so eloquently from Soji? You have the floor.
Thank you very much, Your Excellencies, ministers and colleagues. Can I start off by saying that I'm not a doctor, I'm just a mere lawyer amongst doctors. So for clarification. The first thing I'll say about CHIPS, or I should say health financing, is that it's a problem that exists for every single country, regardless of where you are at the moment in your health system basis. I just read a clip which says that the UK has a problem with the National Health Service at the moment, which has a funding gap of about 20 billion and over that it's looking for. So the fact that you're developing doesn't mean it's going to go away. It's something that Africa should not be feel that we have a problem that we cannot fix, because everybody has a problem. We just have to work harder at it and get it right and learn from the mistakes others have made without repeating them. In our case, we came up with the National Health Insurance Scheme in 2003. And basically, we decided to fund it from state funds, nothing to do with donor funding or sources of funding from elsewhere. We took 2.5% from VAT, 2.5% from SNIT contributions, and then people contributed a sum to get in. At the time when we started, because it wasn't something that had been sold, you had a coverage of about 1 million people in the first couple of years. At the moment, we have a coverage of 11 million people, which is 40% of our population. We are 25 million in total. And frankly, as that number begins to grow, you tend to find that you begin to get a gap between what you can actually collect from those sources as opposed to what the demands are. And it begins to grow exponentially, because the more people realize the benefits of the national health, the more people want to join it. We got to a stage in Ghana where private companies ceased using private insurances and decided to join the national health. Why? Because our basket of coverage was over 95% of what is the basic health issues that go on in the country. So we saw a quick migration of people moving from other forms of insurance or healthcare and coming on to the national health. In a position where your GDP, or for example, you're going into difficulties in the economy, it means your VAT actual figure is not increasing at the same rate. And also your SNIT doesn't increase at the same rate. When there's that is happening as well, for those of us who forget, depression is actually an illness, so people visit more, and so on and so forth. So it mounts up. Whereas when you're in a boom time, you don't feel as much the pressure, because you're collecting more revenue through the VAT. It became quite obvious that one of the things that we hadn't done, and this is the first piece of advice I give, is any national scheme that you put up, you must have a system where you review it between every 5 and 7 years. If you leave it for too long without a proper review of the system, you will get burnt. And we have gotten burnt in that regard. We set up a review system last year, and we have just got the results from the committee that has been put in. It was a non-partisan committee to ensure that it got buy-in from the country. So all participants from other political parties were invited to join it, and it was dealt with by consultants. And they have made various proposals, one of which is for us to look at the possibility of areas where people can contribute, because we have a lot of exemptions. Children under 18 free, old people about 17 above free, all maternal cases free. So we were covering about 60-something% of NHIA payments were actually being paid for by the government indirectly, because actually these were not, these were people who were on the exemption list and are still on the exemption list. So we have to look at the basket that we have and see whether we have to close it, because even in this regard, we haven't looked properly at non-communicable diseases. We also have the fact that this does not even include the fact that the ATMs, namely malaria, tuberculosis, and HIV, don't necessarily fall into that bracket, because we have separate silos for those with regard to how we fund them. If they were to become part and parcel of it, it would be a totally different funding problem. So it's a good thing to have, but you have to know what you're entering when you get in. And the way to go about it is to have a review process between 5 to 7 years each time, to be to play catch up as things begin to tinker or things begin to change. But we would recommend it to each and every one. And the best way for it to work is to go into CHIPS. Do I have a minute? Yes. Yeah. Is to have the community-based system for two reasons. One, a proper community-based system will give you the data that you need. If you have the data, then you know what you're dealing with. And because it's at the lowest level, you get if you have systems in place that give you that data, you're able to deal with it. But then for most of our diseases, they can be dealt with, or illnesses, they can be dealt with at that lower level very quickly. And it also affects your maternal and child mortality if you have the right staff in there, namely midwives or community health nurses. So we would also recommend, just like Ethiopia has done, and you've heard of, I think it's Rwanda, who've also gone into that, and many other countries have different formats of the community-based process that they rely on and helps significantly. On that note, I would simply add that one of the things that will help us in Africa, which is being done, and I give commendation to Moetif on this, as well as my colleagues, like my colleague from Zimbabwe and my colleague from Senegal. There's no point in reinventing the wheel. Anytime I come to meetings like this and I meet them and I have an issue, I go to him and say, what do you think? And he tells me, this is what we did. I take it away and I begin to work with it. Same with my colleague from Ivory Coast, South Africa. So you have to start talking to each other. I do it without any problem because a lot of our ministers change quickly, but the ones who have stayed long, the information they have, you can't buy it in a shop. There's no substitute for experience. So you need to be talking, we need to be talking to each other. And that is what I will encourage to ensure that some of these problems can go away. On that note, I thank you.
Thank you very much, Honorable Minister from Ghana. I think the fact that patients migrated from the private insurance sector to the public sector is a mark of their confidence in the system and in what you were delivering with your national health insurance in Ghana. For congratulations. So congratulations for that, because we normally hear people go in the other direction and of a lack of faith in the quality of services that people can get in the public sector. So that really is commendable. You've shared with us how government subsidy and exemptions helped the poor not to engage in out-of-pocket payments that impoverish them, and emphasize the importance of sharing of experience among countries. Thank you. It's my pleasure now to introduce Dr. Tedros Adhanom Ghebreyesus, Minister of Foreign Affairs and previously Minister of Health from Ethiopia. Honorable Minister, we are all aware that financial resources are meant to support delivery of health services to people who need them. We'd like to hear the experience in Ethiopia. First, describing to us how your country improves service delivery, because we know that that has happened. What capacities do we need to increase community participation in the design of people-centered health services? We are aware that Ethiopia recently completed what is called the joint external evaluation of the international health regulations, that is in relation to preparedness for outbreaks and emergencies. How will you prevent, detect, and respond to future public health crises in line with the national health policy and strategy in Ethiopia?
Yeah. Thank you, Moeti. Thank you, my sister. I'm feeling a bit guilty actually because this session is taking very long, and for taking the stage again. The first one was representing my boss, of course, and this one was allocated to me. So playing both roles. So I will be brief. And instead of describing based on the question that was raised, it will take more time. So I will just outline some of the things we have encountered in our system, which I think for me are the basis of the success. One, from the start, we committed to reform, and we committed for a very comprehensive reform, which covers all the building blocks of the health system. That's service delivery, workforce, HMIS, access to drugs,